to all. Welcome to our IC Management Dilemmas in Glaucoma Demystified. I would like to dedicate my session to Professor Ravi Thomas, who left us very recently. Our team include Dr. Girija, who is the head of the department at Glaucoma Services, Little Flower Institute, Angamali. Dr. Bindu Ajit, Senior Consultant, Glaucoma Services, Comtrust Hospital, Kozhikode. Dr. Vinay Pillai, my colleague and HOD Cornea and Refractive Services, Giridhar Eye Institute, Kochi. Dr. Abhilash Nair, my colleague and Senior Consultant, Cataract and Glaucoma Services, Giridhar Eye Institute, Kochi. And myself, Manju Anup, working as Consultant in Cataract and Glaucoma Services, Giridhar Eye Institute, Kochi. So I'll be talking on the management of ocular hypertension. Ocular hypertension is defined as intraocular pressure more than 21 millimeters of mercury with Goldmann applanation tonometry in one or both eyes on two or more occasions with open angles, no evidence of structural or functional optic nerve head damage, and no other ocular or systemic causes for raised intraocular pressure. So the question here is, do you want to treat all cases of ocular hypertension? Let us look at the evidence from the major landmark trial, Ocular Hypertension Treatment Study. According to the OSTS, 20% reduction in intraocular pressure reduced the incidence of POAG by more than 50%. However, the treatment of all ocular hypertensive individuals is neither medically indicated nor economically justified because of the high prevalence of the disease, low conversion rate to POAG, cost of the treatment, and the side effects of medication. So they have suggested the use of a risk stratification to identify the patients who are at risk, high risk of developing glaucoma, and these patients may benefit from an closer follow-up and early treatment. From the ocular hypertension treatment study, they have found the baseline factors associated with increased risk of POAG. They include increasing age, central corneal thickness, thin cornea, high CD ratio, high pattern standard deviation, and high baseline intraocular pressure. So based on these risk factors, they have classified the population into three groups: the low risk category, medium risk category, and the high risk category. In the low risk group, there is not much significant difference in the mean risk of development of POAG and also the confidence interval between the medication and the observation group. So the risk for progression to POAG is less than 6% in this group, and the number needed to treat is 1:98. That is, you have to treat 98 patients with ocular hypertension to prevent one person going in for open angle glaucoma. In the high risk group, where the risk is more than 30%, they found a significant difference in the mean risk for developing POAG and also the confidence interval between the medication group and the observation group. Here the number needed to treat is 1:7. So the low risk group definitely not require any treatment, they need observation, and the high risk group need definitely treatment. However, in the medium risk group, where the risk is between 6 to 13%, you can decide whether you want to start treatment or observe based on other risk factors. From the pooled data from ODDS and EGPS, a predictive model to estimate the risk of conversion from ocular hypertension to glaucoma has been developed, and in this, they have given some points to baseline predictors. And when the sum of these points is 0 to 6, the risk estimated 5-year risk of POAG is less than 4%, when it is 7 to 8, 10%, 9 to 10, 15%, and 11 to 12, 20%, and more than 12, more than 33% risk of development POAG. So while deciding the management, you have to consider this, and along with this, systemic or ocular comorbidities and family history of glaucoma. So let us look at some case scenarios. This is a case of a 64-year-old male with no systemic comorbidities. Anterior segment and the fundus examinations were within normal limits. Intraocular pressure, mean IOP was 23 millimeters of mercury in the right eye and 24 in the left eye, and the central corneal thickness was normal. Disc square normal, fields were normal. So when you consider the baseline predictors, the sum of the points comes as 6. That means the risk is less than 4%. That is a low risk patient. And here we can observe with an annual follow-up. In case 2, everything is same as in case 1, except the mean IOP has increased to 31 and 33 millimeters of mercury. So when you consider the sum of the points, it comes as 9. That means the estimated risk is 15%. Only the intraocular pressure has raised, everything else is same. So this is a high risk category and you have to start treatment with a 6-monthly follow-up. And you can choose whichever drug you want. I prefer to use PG analog when the IOP is more than 30%, and laser trabeculoplasty is also an option according to the reports from the recent LIGHT trial. Case 3, it's the same as in case 1, except the central corneal thickness which has reduced to 530 from 560. So here the sum of the points becomes 7. That means the risk is moderate. So since there is no other risk factors, and I decided to observe with a 6-month follow-up in this patient. Case 4 is same as case 3, but the pressure has increased to 28 and 29 millimeters of mercury. Here there is high intraocular pressure and also thin cornea, multiple risk factors. And the sum of the points here came as 11 and the estimated 5-year risk is 20%. So this is again a high risk group, and start treatment with a 6-monthly follow-up. Again, the treatment is either anti-glaucoma medications or laser trabeculoplasty. So to conclude, ocular hypertension with multiple risk factors or presence of high risk factors need treatment. Ocular hypertension with less risk factors or presence of low risk factors needs frequent follow-ups to detect the earliest sign of progression to initiate treatment. You have to remember that every patient with ocular hypertension need lifelong regular follow-up regardless of treatment. Thank you. So next talk will be by Dr. Girija. She'll be talking on the management of normal tension glaucoma.
So, very good morning to everyone. Management of normal tension glaucoma. So, whenever the patient comes with you, comes to you with a normal intraocular pressure, but other features like large cup with a thin neuroretinal rim, you are always doubtful whether is this glaucoma or not. Even if the fields show some changes, you cannot start treatment unless you are very sure, because it's a lifelong treatment. So this normal tension glaucoma presents in a very similar manner just as a primary open angle glaucoma, except that the intraocular pressure is always below 21 millimeters of mercury. And always you should, when you are deciding on treatment, you should think about the risk factors, because whether it is normal tension glaucoma or not, you have to be sure. So it's more common in females, older people, and you have to take because the IOP is normal, you have to take a diurnal variation. A facing should be done, and a 24-hour facing is always better, because NTG is associated with nocturnal spikes, which you will not get if you do a office hour facing. And the other vascular conditions like Raynaud's phenomenon, migraine, all are risk factors. You get more incidence of NTG. And the cardiovascular dysregulation factors and other acute ischemic episodes and obstructive sleep apnea syndrome, all these should be kept in your mind when you are thinking about the diagnosis. This 50-year-old male came to us for an RTA management. He had a rupture globe in one eye. The right eye was lost following that. During that examination, we found that the left eye was having a large cup, a 0.8 cup with bipolar notching. And this was in 2019. So he was started on prostaglandin analogs, and he was followed up. And the IOP came down to 10 to 12 millimeter range. But he was on regular follow-up. In 2021, we noticed that the fields are progressing. And since it's one-eyed, we were doubly careful, and we started dorsalamide, which gave an AT of 8 to 9 millimeters. Yeah, even then, the disease was progressing. 2022 HFA also showed progression. So the patient was advised trabeculectomy because he is one-eyed and the disease was definitely progressing, but he was not very keen, and hence we added a third drug. In 2023, he had another RTA. The first admission was for an accident and this one also another RTA, but he came again for follow-up after that, and he admitted history of dozing off while driving, and the wife complained about snoring at night. So because of this repeated accidents, we were also doubtful of a obstructive sleep apnea syndrome, and we sent him to a sleep clinic, and sleep study was done, and it revealed a moderate to severe OSAS, and he was put on CPAP, and the sleep has improved now, but his next field is yet to be taken. So IOP independent risk factors like this has to be thought of when you are thinking about the management and the investigations, because you don't have to do all the investigations in all the patients, but take a careful history about all these risk factors like trauma, inflammation, severe blood loss or hypotensive events, except especially severe blood loss can lead to a single acute episode, but it will not progress. So such history only can reveal such things. So diagnosis can be made. So comprehensive eye examination, including gonioscopy, the regular comprehensive eye examination has to be done with all the routine investigations like HFA and OCT. And these are the usual features of a NTG, less than 21 millimeter IOP, the characteristic cupping, large disc, large cup, dense, more focal and closer to fixation field defects or scotomas, especially which occur early in the disease. So this patient, a 59-year-old male, came with blurring of vision left eye in 2021, and his corrected vision was 6.6. The IOP was normal and the CCT was slightly on the thinner side, but the fundus showed a 0.8 cupping in the right eye with superior and inferior notching, and left eye showed a 0.9 cupping with the superior and inferior notching, and there was corresponding field defects in the eye with the OCT appearance. And he was started on prostaglandin analogs, latanoprost, and he went abroad and he was lost for follow-up for 2 years. Then he came back in 2023, and in the meantime he consulted elsewhere, has taken a HFA which showed some progression of left fields, and he was advised, I think, stepping up of treatment, and he came to us. The IOP on examination was 14 millimeters of mercury, and a detailed history revealed that he was detected as a hypertensive in the 2-year period, and he was started on a systemic beta blocker. So we did the phasing, and there was a nocturnal, there was wide fluctuation in the IOP reading, and we sent him for a cardiology consultation, and the 24-hour BP monitoring we requested actually, and that was done, and it showed a nocturnal dip, and the night dose is changed now. I think they changed the antihypertensive. So unless you take a proper history, you will not know about this. So 24-hour blood pressure monitoring is not done in all NTG patients. So sleep studies are not required in all patients. So only if you take a proper history, you will know what to do. And MRI is another thing. When a young patient comes to you with a large cup, especially if cupping is in excess of pallor, then you have to think about a neurological cause. You take a visual field, and if the visual field is something like this, a vertically aligned visual field defect, then again you have to think about a neurological evaluation. Similarly, color vision deficits in the absence of visual field defects or marked asymmetry of unilateral optic nerve involvement, again you have to think about a neurological evaluation. A 58-year-old female came for checkup, and the fundus showed a 0.65 to 0.7 cupping in the right eye with inferior NRR thinning and inferior RNFLD. And the left eye also had inferior polar notching and inferior RNFLD, and the IOP was in the normal range, normal CCT, but you can see that there is superior arcuate scotoma in both the eyes, and the left eye is showing a paracentral scotoma. So whether to start treatment or not, but because it was not a consistent thing, the disc and the fields were not compatible. So we repeated the visual field some 2-3 times, but it was consistent. So the patient was started on PGA. The IOP was 9 to 10 millimeters of mercury, and the visual fields on follow-up remain status quo in 4 years. So now we are in a dilemma. This is something again we all face, whether to stop the treatment, change the anti-AGM, or to continue. So here it was solved by the family history because the mother has glaucoma, we have continued treatment. But again, you have to individualize treatment. You cannot say that you have to continue in all cases, but you have to individualize the cases and evaluate and decide. So the treatment is, that natural history does not always include progression without treatment, and in CNTGS, 65% of the eyes without treatment showed no progression, and 30% reduction in the IOP has reduced the risk of progression from 35 to 12%. But always monitor the patient without treatment. That should be the suitable initial strategy in many cases. But always discuss with the patient pros and cons of starting a treatment, and it will be lifelong. And progression is usually at a high risk in females, those with a history of migraine, optic disc hemorrhages, greater variations in the diurnal IOP, etc. But it is slower than in a POAG. So you can take time and decide. And exercise and meditation is said to have a positive effect on IOP reduction. So what drug to give in such cases? So medication should be chosen on an individual basis, and the effect of medication on systemic blood pressure, heart rate, and other optic nerve perfusion should be always considered. And the prostaglandin analogs are the single most effective agent in reducing it because it has adequate diurnal control. Beta blockers, but they don't have that much nocturnal IOP control. And the other drugs, again, topical alpha agonists supposed to have a neuroprotective action, though it is not proven in humans. Then topical carbonic anhydrase inhibitors, again they are supposed to improve the ocular blood flow. So all these agents you can try depending on the risk. So all the risk factors you think about. So laser trabeculoplasty, especially the SLT, now has it is giving some promise to this management of NTG. MIGS with cataract surgery, that is again either with cataract surgery or as a standalone procedure, that results in modest reduction in the IOP. But it can reduce the medication burden, and it can actually delay the trabeculectomy. But usually the target IOP here is less than 10 millimeter, and trabeculectomy is the most effective method of achieving low intraocular pressures, and it can blunt diurnal and nocturnal IOP progression. And GDDs are usually it is not the first choice. Trabeculectomy is a more suitable surgical option. And the new IOP independent neuroprotective therapies like memantine, uniprostone, brimonidine even, that's supposed to have neuroprotective action. All these agents, calcium channel blockers, statins, all these are supposed to have some neuroprotective action. That is under research only. And stem cell therapy is the latest one, which can regenerate retinal ganglion cells and produce new cells. And actually RGCs are the ideal target for stem cell therapy because they have the benefit of being confined to the intraocular space and may be less likely to be affected, but it has to be carefully monitored because of the risk of tumor formation. And this is under research, probably that will give us a promising treatment. So the take home message is, it is a diagnosis of exclusion. Always consider the risk factors, get a thorough detailed history, do a careful examination, and do neurological investigation only in indicated cases, and before starting treatment always discuss with the patient. Thank you.
Thank you, ma'am. Thank you for that detailed talk with the case scenarios. The next talk is on management of ocular surface disorders due to anti-glaucoma medications by Dr. Vinay. Over to you, sir.
Good morning, one and all. Thanks to Dr. Manju for having me here as a part of her course. I'm the foreign body here. What am I doing in a glaucoma session? Can I have a slide, please? So the topic is, how to manage ocular surface disorders that arise because of anti-glaucoma medications. So let's start with a case. This is a 71-year-old male who was referred to us in December. Long history of glaucoma. He was with us and many other places. Very, very irregular to follow up. Has been on medication since, as you can see, from 2005 on different kind of medications. He presented with itching redness in 2020. When we went through our old case record itself, it showed that 2017 itself, he was advised trabeculectomy and disappeared after that. At that point of time, the patient had 6/9 vision in both eyes. And this was how he was when he presented in 2020. Okay, his vision was 6/15 and hand movements, which was not improving at all. And this was his clinical picture. Both eyes, there was significant lid edema. If you see the lid skin, there was erythema, mild excoriation. Very angry looking eyes. Okay, red. The conjunctiva, because of the severe congestion. If you can see the lid margin, here, there is mild kind of whitish deposits, which is actually keratinization. Severe congestion, these pale white areas are the subconjunctival fibrosed areas. Okay, if you see the puncta is all closed off, stenosed off, there is no, semicircular fold here, cornea scarred, superficial vascularization, similar picture in the upper lid, left eye almost same, only the area of scarring is more and on different side. But then generally very bad looking eye on the surface. So what is happening here? Obviously, it's a dense cicatrizing conjunctivitis of both eyes with primary open angle glaucoma. Very advanced. So what is causing this here, and how will we approach this case? Before that, yes, in an elderly patient with cicatrization with such angry looking eye, always our first diagnosis is an autoimmune process which is causing progressive scarring, like a ocular cicatricial pemphigoid, or otherwise called as mucous membrane pemphigoid. Then there is another entity which is described called as drug-induced cicatrizing conjunctivitis, DICC, or pseudopemphigoid. Okay, these are cicatrization or scarring happening secondary to some insult which is happening on the surface. Okay, and one of the most common or causes the drug. Which one is happening here? So now, coming to our topic, I'm not going to details, but then it has been shown in many studies that almost 2/3 of the patient on long-term anti-glaucoma medication have developed some or the other problems with the ocular surface. And many studies have shown that arguably this is an ocular surface disease, and its symptoms are one of the leading cause for non-compliance of continued use of AGM in many cases. And because of the induced subconjunctival inflammation, scarring, and all those things, this can result, the surface disorders resulting from prolonged use of AGM can result in failure of drainage surgeries. So what is the pathology here? It is long known that preservatives and drug can affect the surface health. And yes, almost all the glaucoma medications have got some or the other preservatives. In addition to that, it is shown that the drug itself can cause a lot of changes. Okay, so it is not the preservative alone that is a culprit here. The molecule itself can cause the problem. Okay, so what is the problem these molecules cause? Whether it's a preservative or whether it's a drug, it induces inflammation. Okay, it induces conjunctival and subconjunctival inflammation through various different pathways. The whole lot of pathways described, but then all of them result in the final common gate. It results in inflammation, which results in scarring. That is the basic pathology happening here. And two important factors are the duration of the medications used and the quantity. As the number of medication increases, the possibility of getting surface problem increases here. Then another important factor is overlapping demographics. If you see, most of the patients who need anti-glaucoma medication are in the latter half. And if you go through the natural history of ocular surface disorder, especially dry eye, the latter, as the age advances, the prevalence of dry eye increases. Okay, so you have a group which is more prevalent with dry eye disease or surface disorder who has a glaucoma, and on the top of that, you're adding something that kind of disrupts the whole homeostasis on the surface. So existing dry eye will definitely worsen with AGM. If there is, even in cases where there is no surface problem, AGM itself can induce new surface problems and dry eyes. Again, it has been shown that chronic long-term AGM use causes structural changes in meibomian glands and the resultant insult on the tear film and other changes. Okay, versus the meibomian quality thins the lipid layer, resulting in what we call as SPKs or punctate erosions, lid margin changes, and so on. So all this, finally, what does the patient feel? Probably, kind of itching or irritation. There can be periorbital edema, erythema, chemosis, redness or hyperemia. Then as the duration increases, there can be subconjunctival scarring, lid margin changes, corneal changes like erosions, then vascularization, scarring are the results of prolonged insult to the surface. How do you diagnose this? It's basically clinical examination. Staining plays a very vital role here. You can pick up punctate staining, breakup time, Shermer's. These are the three common simple clinical examination techniques which can be used by each one of us or everyone in the clinic. Then one thing which is very underutilized is questionnaires, ocular surface, OSDI, and a lot of questionnaires are there which will show that as the time or the duration on AGM increases, the scores keep going up. Then how do you treat it? If possible, preservative AGM, and I believe that all AGM should be preservative free. Okay, please don't give preservative with preservative. Then there are studies which have shown that concurrent start of tear substitute or lubricant with AGM will or bring about a good effect on the surface. And no financial interest here, but comparison of HPMC with sodium hyaluronate, people have shown that probably sodium hyaluronate has a better role rather than HPMC. Then topical cyclosporin is another agent which can be considered to control the disease, or probably you can think about starting it early when when the patient start complaining about problems on the surface itself. Okay, these are two things which can be implemented very easily. Then in established cases where there is severe inflammation, we have to control the inflammation at the risk of getting shot in a glaucoma quorum here. You will need steroids to control here. Then the associated features. In this case, which I mentioned, we stopped the offending agent, put her on oral, Diamox, had to use steroids to control. We did a biopsy, and then Manju did valve in both eyes. And finally, we did cataract, and this is how the patient ended up. Quiet eye, comfortable patient, happy patient, 6'9", 6'18" vision. Yes, prevention is always better than treating it, but is it always possible? At least we can try. Preservative free. Take a detailed history. If there is a history of suggestive of some symptoms of dry eyes or surface disorders, anticipate worsening, start treatment early, and actively look for problems. I'm no way can suggest any of this, but probably you can think about alternatives or medications early in the disease process, especially if there is no response to treatment to disorders, or if there is progressive worsening. Thank you.
Thank you, sir. Thank you for the talk and giving some guidelines regarding the management of ocular surface where you don't have an in-house cornea person like me. Our next talk is on management of primary angle closure disease with cataract by Dr. Abhilash Nair. Over to you, sir.
At the outset, I'd like to thank my colleagues in helping me prepare these slides. So my talk is primary angle closure disease with cataract. Now, we all know that cataract and glaucoma have they cause lots of blindness. They are the major two factors that cause blindness in our population. And when you have glaucoma with an open angle, you have a cataract with an open angle glaucoma, it's probably easier to treat the patient because both these diseases can be treated separately. But in an angle closure patient, the problem is the cataract itself forms a part of the etiopathogenesis of the glaucoma. So it is difficult to treat each separately. You have to take into consideration the lens as a problem with the etiopathogenesis of the glaucoma also. So we all know that the lens increases in thickness with age, and most of the anterior segment OCT parameters like vault and thickness and lens position, all these are associated with the formation of angle closure disease. And if you add sonular weakness to that mix, then you will definitely develop a lot of problems with angle closure. Now, even without an equipment like an ASOCT, can you make out whether the patient is having a primarily pupillary block disease or whether it's a lens that is causing the problem? Now, in a primarily pupillary block problem, the central cornea will be deeper than the periphery. Now, in a primarily lens-induced problem, it will be uniformly shallow. It's because the iris is always touching the lens from the periphery to the center of the cornea. Yeah. So it will have something called as a volcano-like appearance. Now, if the patient has angle closure is a suspect, then you can probably observe, because there is a low chance that it might progress to angle closure itself. And cataract management can be done as you would manage cataract in any normal patient. If the patient is PAC category patient, then you will need an LPI, because that will prevent IOP spikes, and if you are doing some intervention, that will prevent the chance of malignant glaucoma. Cataract extraction can be done earlier. You can advise the patient to undergo cataract earlier than what you would usually do, and you can do the cataract surgery alone. You need not do anything for the glaucoma apart from maybe medicines. The patient has already developed glaucoma. Now this becomes difficult, because first you have to treat the glaucoma part. You have to bring down the IOP. The ACPI is very much essential, and do the medical management that you would normally do for a glaucoma, so that the pressure comes more or less tolerable. So what are the options available? One is TRAB alone. You can do cataract surgery alone, or you can do a combined surgery. So when do you suggest each of them? Now, if you do a TRAB alone, the long-term pressure control becomes easier. Many eyes don't require medications. You might need few medications, but many don't. But TRAB is always associated with a lot of complications. So you will have to do secondary procedures. You have to be prepared to do maybe needling or resuturing, or maybe suture removal, laser suture lysis. And TRAB has been shown to hasten cataract progression. So patient will have cataract within a few months or years down the line. Now, cataract surgery alone can be advocated if the PAS is less than 180 degree, there is minimal optic disc damage, and the patient's IOP is actually controlled with 2 or less number of medications. Phacoemulsification does cause reduction in IOP in angle closure patients, but it is always less than what you would get by doing a TRAB. And compared to TRABs, you will have to use more number of drops. The complications are inherently less because it's a closed chamber procedure. It's not an open procedure like trabeculectomy. And the success always will depend on what the angle profile is post surgery. The best corrected visual acuity is better at 3 months duration, but around 6 to 12 months. Compared to a combined procedure, it was the same. Combined procedure is probably a better way to go, though the visual rehabilitation is delayed, because when you take the cataract alone, the cornea is probably much better off post surgery. Complications are more, but the number of anti-glaucoma medications are less. So let's come to a few cases. So this elderly gentleman, he came for blurred vision for around 1.5 years, diabetic and hypertensive. Now the right eye is having very less vision. IOP is around 24. Left eye is better off. Vision is 6, 9 and 6. And cataract in both eyes. Left eye IOP is 22. Angles are closed. Both eyes closed. So initially we start on medication so that the pressure comes down to a normal value. PI is done in both eyes. Now, gonioscopically, the right eye is still closed, left eye is open enough. So, probably the left eye we can observe for now. Right eye, since he is having cataract, probably we'll have to do a surgery for the right eye is having dense cataract. So, cataract surgery should be able to, bring this glaucoma to manageable levels. Coming to the next case, elderly lady with blurred vision of 3 months duration. There is a family history, and right eye is 660, left eye is just CF 1 meter, both eyes cataract. Right eye is having 24 millimeters of mercury, and left eye is very high, 36 millimeters of mercury, with closed angles in both eyes. Both eyes having synovial closure. This is the right eye, moderate degree of cataract. Left eye, more severe cataract. Both eyes showing a shallow AC. We did manage to see the fundus, so the right eye was seen to be rather normal, while the left eye was having advanced glaucoma, and patient was started on medicines to bring the IOP a bit lower. PI was done in both eyes, and the patient, even with the PI and the medicines, the pressure came down to only around 16 and 28 left eye. So patient was taken up for combined surgery, and though initially it looked rather red eye, it gradually resolved, and over past 2-3 weeks the bleb is functioning, IOP is lower. Long term we'll have to see how well it goes, but as of now it's much better. Coming to the third case, elderly gentleman, he actually presented with acute angle closure. He was seen elsewhere and started on medicines, and he was referred for further management to our place. So right eye already undergone surgery many years ago, sat on the other eye, didn't do anything for that, not motivated to do surgery in the other eye, and it landed up with angle closure and acute glaucoma. So pressures were 26 in the left eye on anti-glaucoma medications, and these the right eye and the left eye having mature cataract with very shallow anterior chambers. Gonioscopically closed in the left eye. We did YAC-PI, slight amount of improvement. Now this YAC-PI is very important, because otherwise you don't do this, you will end up with malignant glaucoma. More chance of malignant glaucoma if you do a combined procedure. So PI was done, and patient advised cataract surgery. Cataract surgery was done. The surgery didn't go on well. I don't have the photos. He had vitreous loss. We had to do, I think, an iris fixated lens. So not a happy ending, but still we have to do what we have to do and hope for the best. The next case, elderly man, blurred vision of both eyes, again started on glaucoma medications elsewhere, but the patient stopped anti-glaucoma medications 1 week previous to visit to our place. So right eye is having RAPD 6-9 and 6 vision, left eye 6-12 and 6 with cataract, pressures both eye 22. Angles closed in both eyes. PA was done in both eyes, and you can see the PA's photo is there. So with the PA itself, the pressure reduced to 16 in both eyes. Angles open in both eyes. So this is a happy situation. Like the PA itself is able to convert the angle closure to a rather moderately open angles. You can follow up these patients. You need not probably even start medicines. If the patient is willing to come for follow-up, you are sure that the patient follow-up, just continue following up. And this is a photo. Right eye is having glaucoma, left eye is okay, feels. Thank you.
Thank you, sir. Thank you for that talk. Where when there is coexistent cataract and glaucoma, it's always a dilemma what to do, whether sequential or combined. The next talk is on management of failed trabeculectomy by Dr. Bindu. Over to you, ma'am.
Thank you, Manju, for the opportunity. Now, when we do a trab, and what we dream of is a ideal bleb which is diffuse with a good height, avascular and microcyst. But not always we encounter this. We do encounter angry looking blebs or a low height bleb, or it is a cystic bleb, or you get a flat fibrous bleb with vascular or a flat bleb. So not to worry much, because the incidence subconjunctival and episcleral fibrosis 20% in early stage and 30 to 40% in the late post-op, and subtenon's encapsulation is 10 to 20%. So now we'll just see how we fight to convert this failure to success. So before understanding this, we have to understand the stage of healing so that we can intervene accordingly. So in the initial stage, you have to identify failure. That is the first and foremost thing. The signs are the hyperemia, the excessive vascularization, increased intraocular pressure, and during the months and weeks, it comes to small bleb, an encapsulated bleb with a ring of steel, a small avascular cystic bleb to a flat bleb in the late stage. So when we are planning for surgery, we have to consider the predisposing factor, like when a patient is on a maximum eye drops, a patient with neovascular glaucoma, uveitis, aphakia, and a history of prior surgery and eye syndrome are prone to go for failure. So now we have a failed bleb, and how to intervene depends on the stage of where we identify the failure. So it starts with the surgery itself, where you need to have a bloodless field. Try to be less traumatic as possible with blunt dissection and proper hemostasis. And during the early stage, there is a lot of inflammation going on, and that time you upregulate the steroids, and we just follow it up. So the first and foremost is to identify whether the ostium is patent. Do a gonioscopy and identify if the ostium is patent. If not, you have to address that issue first by either YAG laser or surgical intervention. And then, as I mentioned, preoperatively, we have to give steroids if it is a high risk case and it's going for failure, and minimal trauma during surgery. And the other major factor is we have to use the modulators like the mitomycin. Earlier we used to use the sponges. Now we are more into injections, which give a precise quantity of the drug into about 7 millimeters away from the limbus, and you diffuse it posteriorly. You don't have to fear of leaving around the sponges, and you have a more uniform spread of mitomycin. And then during surgery, when you pre-place releasable suture, it gives you an advantage to titrate the pressures in the post-operative period. Initially, we used to do it from the corneal end, and you have the loose sutures coming out and producing the windshield wiper. Now, if you start it from the scleral end, you have a loop there which does not come out easily, and you can remove it when necessary. So the interventions when we are doing it before an organized fibrosis is within 2 to 3 weeks. Initially we go for a bleb massage, and then we can do this laser suture lysis or release the releasable sutures, and also we have the 5FU injections. So initially when you do a digital massage, it is not doing it. You have to assess how much pressure is needed to bring about the drainage. That gives you an assessment of how much fibrosis is happening there, and which area is the bleb is forming, because it gives you an idea of which suture to release first. Just see the bleb forming when you're doing a digital massage. And then you can remove this releasable sutures from the slit lamp. If the bleb is flat like this, just remove this. You just pull it towards the lower end, and should be in the same line of sutures. And then after that, you can do a massage and see the bleb forming. Or you can opt for suture lysis with the special lenses, but there is always a risk of conjunctival buttonholing and subconjunctival hemorrhage, which again can lead to fibrosis. The 5FU injections, they have a more localized effect, a shorter half-life, and a fewer complication. It can be used in a congested bleb. You can start it in the second week with a dose of 5 milligrams subconjunctively weekly. So if you have a high IOP post-trab in the earlier period when the ostium is patent, within a week you do a bleb massage. I'm not able to see it here. Okay. Within 1 to 4 weeks, you do the releasable suture. And if it is a cystic bleb in the early stage, you do conservative management with ocular massage, give aquasuppressants and increase the steroids. But if it is not settling, then we'll have to go and do the needling. Here you can see the work in the mouse. This is the ring of steel which is preventing the blood from flowing backwards. So you use either a 26 gauge needle or 30 gauge needle. First you inject a local so you get the plane and then go and break the fibrous bands. So once you have done it, you can give an injection, either 5-FU or mitomycin after that, away from the bleb. So this is the post-kneading bleb. Now your bleb is well formed. Sometimes on a flat bleb, we'll have to go into the subscleral plane, under the scleral flap, and then do the needling. In the late stage, when it is a flat bleb, you can do the needling under the flap itself. This is how you revive the bleb. The complications when you do needling are SC hemorrhage, needle tract leak and conjunctival buttonholing. It can cause hyphema and if too much, choroidal effusion and hypotonia is also complications which you can encounter. So when you have done the needling and again it goes into failure, you have no other option but go for a repeat trap. And if some cases like the silicone oil going and causing fibrosis and failure of the bleb, you will have to resort to the tubes, glaucoma drainage devices. To summarize, primary prevention, preoperative steroids and stop anticoagulants. Intraoperatively, optimal cautery, application of mitomycin in a more diffuse and posterior way. Postoperatively, look for signs of failure, titrate the topical and systemic steroids and do laser suture lysis or remove the releasable sutures. Digital massage. If the iris is an ostium, pilocarpine, YAG laser and repositioning. Needling with subconjunctival or subscleral with 5-FU or mitomycin. And if this fails, go in for a revision surgery for a repeat trap or a tube. So the first to 6 weeks is the most crucial. You have to identify and act appropriately and then you can revive the bleb. Thank you.
Thank you, ma'am. Thank you for explaining the management of failing bleb with videos. Now, any doubts from the audience?
Preoperative steroids, how long do you give and what steroids are preferred in giving the preoperative period?
I usually give prednisolone 1 week before.
What about steroid responders that can lead to an increase in the IUP?
Initially, we also give acetazolamide to take care of the pressures and prepare the patient before surgery. So it does, even post-op, you are going to continue the steroids.
Another question is, in case of primary angle closure with cataract, do you do YAG-PI for all patients before surgery or directly go ahead with the combined?
I usually do a YAG-PI because it makes the surgery easier. Otherwise, with the available small space, there is likely to have you are likely to have corneal endothelial damage and difficulty when you are doing a phaco. So better to do a YAC first and then proceed with the cataract surgery or the combined.
My question is to Dr. Abhilash. Phacomorphic glaucoma, should you do a YAC PI for all the patients?
See, phacomorphic glaucoma, I think so. Yeah, I think it's better because it's an ankle closure disease, and once you enter, if you don't have even that much of space, as Madam said, it may not, work out in your favor. You might remove the cataract, but you'll have complications.
Do you think YAC PI can increase the AC depth in phacomorphic glaucoma?
At least a bit, so that you can at least inject something. Otherwise, once you make that paracentus, it's the iris that is coming out. Already the iris is outside.
So you were talking about combined surgery like cataract surgery with phacomorphic glaucoma. For that, should you do a PI or not? Like you were telling, to prevent malignant glaucoma.
If you have the time, it's better to do the PI. Like if you can't control the glaucoma at all, there is no way you can control the glaucoma. Cornea is very hazy. You can't do a PI, or you risk getting a corneal burn, and there is absolutely no way. Then there is no option. Intravenous mannitol, Diamox, control the IOP as far as possible, and go ahead with your phaco trap.
Thank you, sir.
But probably if you are able to do a PI, you are able to visualize the iris, you can focus it, probably better to do a PI.
Thank you, sir.
I think if it is not an acute angle closure attack where the pupil is at least a bit dilated, better to do a PA. Otherwise, maybe the patient can go in for an acute attack while waiting for the surgery. That is also possible. So if it is dilated, mid-dilated, fixed pupil, okay. Otherwise, I think you do a YAC PA, which will help you anyway.
And I was just thinking about phacomorphic glaucoma. Like
that's what. Even then, while waiting for the surgery, we dilate. No, there is a possibility that patient can go in for an acute attack. While once it is dilated, and if it is getting delayed to take out the lens. Okay.
Early, then there wouldn't be any clinical closure. You can go away with even cataract, but you have to be prepared with your mannitol. But if the patient is 2 weeks, they can take with already the clinical closure occurred, and then you might find it difficult. You might have to go for a combined or after PI. And you can use on-table dilatation. You can use the topical agents, intracameral agents that are available.
Intracameral phenocane is now available, or adrenaline you can even put, and you can dilate it on table and then proceed with the surgery. If if the AC is that flat, otherwise it's always better to go after a PI.
While diagnosing NTG, before starting, as initial only, will you do some baseline systemic evaluation, or if there is a progression, you evaluate systemically in case of NTG?
Most of NTG patients, they are in that age group where they have some comorbidity will be there, and they'll be on under the care of a physician. So that evaluation is already, they will be under treatment for some hypertension or diabetes, and some physician care will be there. So if you want to evaluate, you can send them if you are suspecting. But all patients, before diagnosing an NTG, it is better to have a medical evaluation if you are suspecting any of the other risk factors. Because NTG, it's very easy to diagnose and then start treatment just like that, because you're seeing a cupping, some field effect, then you start an anti-glaucoma medication. But it is for lifetime. So you have to think about it better do a systemic evaluation and then start the treatment.